This recorded lecture will be going over Chapter 29, The Child with a GU Condition. Figure 29.1 on page 687 depicts the structures of the urinary tract and illustrates how they differ in the developing child and in the adult. There is an unexplained relationship between low-set ears in the newborn and urinary tract anomalies. Figure 29.3 on page 688 shows the female and male reproductive systems and lists some of the differences between children and adults. Common laboratory tests to test for these anomalies are reviewed on page 689 within table 29.1. Some terms commonly used to describe urinary dysfunction terms include dysuria, frequency, urgency, nocturia, enuresis, polyuria, and oliguria. You can read these definitions on page 689. Phimosis is a narrowing of the preputial opening of the foreskin, which prevents the foreskin from being retracted over the penis. You can see a picture of this on page 689. This is normal in newborns and usually disappears by 3 years of age. Circumcision can correct this condition. Postoperatively, the penis is covered with a petroleum gauze. The penis is tender and may burn on urination. Forcible retraction of a tight foreskin is avoided because it could lead to paraphyminose. Hypospadias is a congenital defect in which the urinary meatus is located not at the end of the penis, but on the lower shaft. With epispadias, the opening of the urinary meatus is on the upper structure of the penis. Hypospadias is fairly common. In many mild cases, surgery is not necessary for either condition, unless the location and extent of the defect are such that the child will not be able to stand to void, or the defect would cause psychological problems or difficulties in future sexual relations. Treatment consists of surgical repair and is typically performed between 6 and 12 months of age. In exstrophy of the bladder, the lower portion of the abdominal wall and the anterior wall of the bladder are missing. This disorder is noticeable by fetal sonogram. Urine leaks continually from the bladder. The skin around the bladder becomes excoriated. The bladder is covered with a plastic shield or appropriate dressing to protect its mucosa but still allow for urinary drainage. Antibiotics are given to prevent infection. Surgical closure is ideally performed during the first 48 hours of life. Many conditions, such as calculi, tumors, strictures, and scarring, can cause an obstruction of the normal flow of urine. Hydronephrosis is the distension of the renal pelvis as a result of an obstruction. Urinary diversion is necessary in certain conditions and may be accomplished by several procedures. You can read about some of these procedures within Table 29.2 on page 691. Stress from the urinary diversion is age-related. The nurse anticipates the impact of this type of diagnosis and incorporates suitable psychological interventions into their daily care. To assess for a distended bladder, the nurse should gently palpate below the umbilicus, moving towards the symphysis pubis. In the neonatal period, uncircumcised boys have a higher incidence of UTIs because of the pathological organisms can become trapped in the space between the prepuce and the glans penis. It is important to teach parents proper care of the circumcised and uncircumcised penis, as well as the principles of perineal care. In girls, the incidence of UTIs is highest in the infant and toddler years and with toilet training. Incest or other sexual abuse should be considered in young girls with repeated infections. Alkaline urine will favor pathogens. Urine that remains in the bladder for a prolonged time will serve as an excellent medium for bacterial growth. Vesicoureteral reflux refers to the abnormal retrograde flow of urine from the bladder to the ureters during a void. You can see a good depiction of this on page 692 in figure 29.7. The signs and symptoms of UTI are age-dependent. The infant may be admitted with a high fever, vomiting, and chills. A urine specimen for culture should be obtained before antibiotics are administered, and urine specimens should not be collected from the diaper. Infants younger than 1 year of age are typically hospitalized and observed. For severe reflux, an endoscopic procedure will inject a bulking agent via a subtrigonal injection, known as a sting, into the mucous membrane of the ureter to prevent retrograde flow of urine. Open surgical intervention is reserved mostly for significant anatomical defects. Methods of preventing UTIs are taught to parents and to the patient if age appropriate. Nursing Care Plan 29.1 on page 693 presents nursing considerations and appropriate care for these patients. Nephrotic syndrome refers to a number of different kidney conditions that are distinguished by the presence of marked amounts of protein in the urine, edema, and hypoalbuminemia. The characteristic symptom of MCNS is proteinuria and edema. The child gains weight because of the accumulation of fluid. The abdomen may become distended. The child is pale, irritable, listless, and has a poor appetite. Blood pressure is typically normal. Urine examination shows a massive albumin and a few microscopic red blood cells. The goals of treatment include minimizing edema, preventing infection, reducing the loss of protein in the urine, and preventing toxicity from the medication prescribed. The child with nephrosis is given medications designed to reduce proteinuria and consequently edema. Steroid therapy is currently used for this purpose. The patient should be watched closely for more subtle symptoms of illness. Diuretics have not been effective in reducing nephrotic edema. An attractively served, well-balanced, low-fat diet is desirable because the appetite will often be poor. Fluids are not usually restricted except when massive edema is present. The nursing care of the child with MCNS is of the greatest significance because the disease necessitates long-term therapy and the child has an increased susceptibility to infection. The child is periodically hospitalized. Parents are instructed to keep a daily record of the child's weight, urinary protein levels, and medications. The child should be turned frequently to prevent respiratory tract infection. Their intake and output should be strictly charted. Diapers may be weighed on a gram scale before application and then after removal. 1 gram equals 1 milliliter. If a 24-hour urine collection is ordered, every voided specimen within that time must be saved, or the test will not be valid. The patient should be weighed 2 to 3 times weekly to determine any changes in the degree of edema. Abdominal girth should also be measured daily. Nurses should make every effort to protect the child from exposure to upper respiratory tract infections. The vital signs of a patient with nephrotic syndrome should be taken regularly. Home care during remissions is preferred, with parents being taught monitoring skills. Acute glomerulonephritis is an allergic reaction to a group A beta hemolytic streptococcal infection. It may appear after the patient has had strep infection, scarlet fever, or skin infections. Glomerulonephritis is the most common form of nephritis in children, and it occurs most often in boys 3 to 7 years of age. On page 695, table 29.3 will compare nephrosis with AGN. The prognosis for AGN is excellent. From 1 to 3 weeks after a streptococcal infection has occurred, the parent may notice that the child has periorbital edema when awakening in the morning, and that the child's urine is smoky brown or bloody. The urine output may be decreased, and the urine-specific gravity will be high. Albumin, red and white blood cells, and casts may be found upon examination. Although children may feel well, activity should be limited until gross hematuria subsides. Because renal function is impaired, there is a danger of accumulating nitrogenous waste and sodium in the body. Dietary sodium and fluid restrictions are based on the hypertension and edema present. Prevention of infection and fatigue, maintenance of accurate intake and output records, and frequent monitoring of vital signs are essential. They must understand the importance of continued medical supervision because follow-up urine and blood tests are necessary to assess progress towards recovery. Wilms tumor, or nephroblastoma, is one of the most common malignant renal tumors in early life. About 2/3 of these growths are discovered before the child is 3 years of age. A mass in the abdomen is generally discovered by a parent or by the healthcare provider during a routine checkup. Renal damage can cause hypertension. Treatment of patients with Wilms tumor consists of a combination of surgery, radiation therapy, and chemotherapy. General nursing measures for the comfort of the patient are implemented. One important consideration pertaining to this condition is the avoidance of all unnecessary handling of the abdomen, because rupture of the capsule could cause the tumor to spread. Postoperatively, contact sports should be avoided to prevent damage to the remaining kidney. A hydrocele is an excessive amount of fluid in the sac that surrounds the testicle and causes the scrotum to swell. Its appearance in the newborn is not uncommon, and in many cases, the condition will correct itself by the time the child is 1 year of age. A chronic hydrocele that persists beyond 1 year can be corrected by surgery. The testes in cryptorchidism could remain in the abdomen or the inguinal canal. This condition is common in approximately 30% of low birth weight infants. When one or both testes fail to lower into the scrotum, the condition is called cryptorchidism. If both testes are affected, sterility will result. Acute scrotal pain could indicate a testicular torsion. This will necessitate immediate surgery to preserve testicular function. Occasionally, a testes or the testes spontaneously will descend during the first 4 months of life. An operation called an orchiopexy can be performed by the time that the child is 6 to 15 months of age. Parents should be taught to teach the growing child the importance of self-examination of the testes. To give emotional support, the nurse caring for the child should know what the child has been told and how he feels about the operation. The nurse should assure the child that his penis will not be involved in the surgery. Surgery of the urinary or genital tract affects growth and development. Between 3 and 6 years of age, the child becomes curious about sexual differences and may masturbate. Surgical interventions during this stage of development necessitate guidance and preparation to minimize the negative impact on growth and development. Adolescents may be concerned about the effects of surgery on their appearance and sexual abilities.